we have a, I'll start it there. Welcome everyone. We have a great and growing group here to talk about the patient safety structural measure. I know that looking at the participants on this call, we have so many people who have been involved in different measures with CMS in advancing the underlying work that this structural measure supports. And I think for many of you on the call, some of the things that are supported in the structural measure are your lifetime work. And really excited to see this structural measure being moved forward and talk about it today. So we have Rosie Bartel, Tom Gallagher, Tejal Gandhi, Marty Hatley, Carol Hardeep, and I are all going to speak today.
But talk or what? I am, but okay.
I think, Lisa, maybe put yourself on mute for a second. All right.
Okay.
So we good, Marty?
Yep, we're good.
Okay. So these are our presenters today. I don't think we have any disclosures. Almost all of us were involved in the structural measure process, and so that's why we're here to share our thoughts and our contributions to the development of that measure and as proposed through the MUC process at CMS. If you want to move forward. Just a reminder, if you could put your phone or computer on mute if you're not presenting. So we have a couple people who are whose noise is coming in, so that would be great. So the objectives of today's call are to, one, inform the patient safety community, our champions and strategic partners with Patients for Patient Safety, about what is this new structural measure. And then also, and most importantly, is to encourage all of you to participate in the listening session that's coming up on December 15th. And also to, if you're not able to participate, Lisa, can you mute your phone?
Beth, you're on mute.
I muted Beth by mistake because I was trying to.
You're trying to mute the other people who were talking.
Okay.
We'll get this together.
You're back.
All right, I'm back. So anyway, so the main goal of this is to inform everyone about the patient safety structural measure. And this is a process that's really happening right now. And I know you're all busy with the holidays, busy with work, but we have a very short window for public comment. And there's a listening session on December 15th, and there's a process for public comment that we need to get to support this measure in the coming month, really in the coming weeks. So we'd really love all of our champions, partners to consider writing a public comment in support of the measure. And we'll tell you how. Okay, so what is the structural measure? It was published on December 1st in the CMS MUC list. And I always laugh when it's called the MUC list. MUC means measures under consideration, but it does sound kind of like muddied water. But needless to say, despite the name, it is where the CMS develops the measures that end up becoming the guidelines for hospitals, for skilled nursing facilities, for ambulatory centers, and so on and so forth, that guide their accreditation, also guide their payment. And so this is a structural measure, and there are multiple kinds of measures. Many of you already know this. This measure was developed by Yale at the Center for Outcomes Research and Evaluation, which was contracted by CMS to develop the measure. There are payment measures, there are structural measures. This is a structural attestation measure, so it will not technically be linked to payment, but will be more like the birthing and birthing designation measure that allows recognition for institutions that are really showing an incredible commitment to safety, or in that case, maternal and birthing, advancing maternal and birthing processes. So the Yale core measure was developed, and the next step in that measure process is it goes through this pre-measure review. That's the current step that we're in, where we take feedback and recommendations on the specifics elements of the measure. This measure aligns with the CMS quality strategy, and it also aligns with the IHI's ARHQ IHI developed National Action Plan to advance patient safety, which I know many of you were involved in. That National Action Plan, which is commonly called the NAP, and the CMS quality strategy, both of those were really developed and have a huge pieces of them. Well, the National Action Plan is all about patient safety, but the CMS quality strategy, a very fundamental piece of that, is how do we address some of the regression in safety and help institutions, support institutions to reprioritize safety, to re-engage in safety, and to make it a systemic element that they're in their entire operational plan. That's something that they have as part of how they work all the time. So this is part of the longer CMS measurement strategy to use public reporting to generate data and convey these priorities to Medicare providers. So the patient safety structural metric is really in alignment with the CMS quality strategy and the National Action Plan. It covers leadership, governance, strategy, and culture issues. It really is focused on both patient safety and health equity. It takes patient safety best practices that have been shown to work and that institutions that lead in the CMS safety metrics are using, and encourages all institutions to use those metrics or use those processes. And the attestation measure in the patient safety structural metric supports that. It also encourages some practices that many institutions are not using, to the frustration of many people on this call. Things that are really lagging in implementation, like patient and family engagement. In particular, since that's fallen off since COVID, this puts it front and center and encourages institutions to reconsider what they're doing to support patient and family engagement. It also provides a little bit more guidance for hospital leadership on what patients and families expect. One thing that I think is unique about this patient safety structural metric is that it really involved patients in the process in its development. And a lot of times when these metrics are developed, patients are not on the metric development committee. And quite the opposite was in this case. A lot of times patients are sort of reacting to the metric that's developed. And this was a very impressive process where patients were integrated into the metric development from the beginning and being asked to consider, what does safety look like from the patient's perspective, and how would that represent itself in the safety structural metric. So we were really excited because that's pretty unique, and we think that is reflective in the work of the metric, and all the more reason why I think the patient safety advocacy communities are incredibly excited about the patient-centeredness of this metric. So I talked about the patient-centeredness, and then last, this really looks at public reporting, which has been struggling over the years, that and we all certainly saw that with the Vanderbilt case, where that was very public. But I think we all know, every institution, we all know in our own institutions that harm is happening, and a lot of times learning from that harm is not happening because there's no reporting and sharing of that information. So this reinforces it, not as a sort of a gotcha, but as a learning mechanism. And that's really a thread throughout the patient safety structural metric, that, how do we look at identification of harm, sharing the improvements from harm as learning opportunities, not as things to hide. So, some of this is really kind of how organizations should function and operate and lead and engage patients. And I think that's reflected in the wording of the different elements of the metric.
Okay.
And slides will be shared at the end. And I'm going to hand it off to Carol. And there are 5 domains. And so, we didn't want to end with patient and family engagement. It is domain number 5 in the sequence of the patient safety structural metric. But for our group, we put domain number 5 in the first in this presentation because we're really excited about some of the guidance. So I'd like Carol to share the exact wording of that domain so that everybody's clear on what it's encouraging. Go ahead, Carol.
So welcome, everyone. We are going to break a cardinal rule of literally reading what's on the slide, but we feel it's important. And then I'm going to add just some comments or color commentary to what we think are highlights of these various measures. So the first one is our hospital has a patient and family advisory council that ensures patient, family, caregiver, and community input to safety-related activities, including representation at board meetings, consultation on safety goal setting and metrics, and participation in safety improvement initiatives. What I want to call out here is this is the evolution of PFACs. These are more sophisticated PFACs with the fact that patients and families are part of the goal setting, but more importantly, we're part of the safety improvement initiatives. We're helping to drive, maybe it's different hack work or disease state, but we're not there to be part of picking room colors and redesigning parking lots. It's that next evolution of what patients and families can do. The second one is our hospital's patient and family advisory council includes patients and caregivers of patients who are diverse and representative of the patient population. We know so many of us that have done this work tend to be a lot of people of white people and females. And we are not so oftentimes representative of the census of the various organizations. So hold on just a second. Sorry. So what we're asking organizations to do is look at what is their census and does their PFAC make up the percentage of the census of their organization? The third one is patients have comprehensive access to and are encouraged to view their own medical records and clinician notes via patient portals and other options. And the hospital provides support to help patients interpret information that is culturally and linguistically appropriate, as well as submit comments for potential correction to their record. This is really tied in to patients and families being part of the team. Those of you that have been following the 21st Century Cures Act, it also is showing that we have the right to have access to our medical records in real time. And there are actually penalties if we do not get access to those records. And the third thing that I'll add here that's really important, that is after harm events, it is important that we have access to our records and that they're not delayed or incomplete. So it is just patients having real-time, full, complete access to their records and being able to fix mistakes that sometimes are in the records that can be deleterious to their care. Next slide, Marty. The next one is our hospital incorporates patient and caregiver input about patient safety events or issues, such as patient submission of safety events, safety signals from patient complaints, or other patient safety experience data, patient reports of discrimination. The key here is pointing out that we have mechanisms that we can actually report and share our experiences. And we're seeing this some, but patients and families oftentimes don't know how to share that. So where can we help be part of improving the system and the learning by have mechanisms to share these signals or actual issues that we see happening? And the final one is our hospital supports the presence of family and other designated persons as defined by the patient, as essential members of a safe care team, and encourages engagement in activities such as bedside rounding, shift reporting, discharge planning, and visitation 24 hours a day as feasible. We are not visitors in our loved ones' lives. Being there to help them physically, emotionally, spiritually, and also help the care team and being part of the whole process. So with that, I'll turn it over to you, Marty.
Okay, and we are going to go. Thank you, Carol. And we are going to go to Hardeep.
All right, sounds good. I'm delighted to be here and give you my perspectives on hospital leadership and how they can be engaged in patient safety, something we've been trying to do for the last 2 decades. So let's go with the same sort of format. I'll read the first item and then I'll give you a little bit of my perspective. So our hospital senior governing board prioritizes safety as a core value, holds hospital leadership accountable for patient safety, and includes patient safety metrics to inform annual leadership performance review and compensation. Well, I really like this one because not only does it emphasize the core value, in patient safety, but also ties patient safety to something that the leaders really care about: their own performance, about how people feel about them, and their money that they receive. So imagine if we can tie in bonuses of CEOs, CMOs, and other C-suite folks to patient safety related issues. That would usher in a new era of accountability because we know that extrinsic motivators really work. So this is one of my favorite ones, and I hope all the leaders will pay attention.
That's okay. I just have a minute too, because I'm gonna.
All right, so we need everybody to mute themselves. I'm hearing from Wanda right now.
See you later. Bye.
So second is our hospital leaders, including C-suite executives, place patient safety as a core institutional value. One or more C-suite leaders oversees a system-wide assessment on safety, and examples are given, and the execution of patient safety initiatives and operations with specific improvement plans and metrics. These plans and metrics are widely shared across the hospital and governing board. So here's my sort of take on this. If you look at this closely, there's 3 important items in this measure that we need to be paying attention to. The first is who's in charge. If everybody's in charge, no one's in charge. If you diffuse the responsibility of people taking action, nothing will get done, right? So holding a few people accountable at the C-suite level, whether it's 1, 2, or 3, and ensure that they are the ones taking action is really a good thing. We've seen sort of these with specific patient safety issues. We've been trying to improve the problem of missed test results for decades now. But one of the reasons that hospitals sort of and other health systems have a problem with it is there's nobody in charge to fix that problem. Is it primary care? Is it a specialist? Is it the quality officer? There's always often this diffusion of responsibility. So it's really good to sort of assign responsibility. Second thing, if you look at it, is it ties it to specific assessment issues. So, right. So if you have a plan, that's great. If you have people, that's great. But how do you implement that plan, right? So there's so many tools to assess system-wide, do a system-wide assessment on patient safety, but they're not being used. And, they've already come up in this call. So that would be the second item that I think is important within this item number 2. And the third is communication and dissemination of information. So if leaders start communicating what they are doing on patient safety, it sort of changes the culture of the institution and slowly. So I think that's really important. So sort of showcase what you're doing, communicate to people, and share that information across. So sort of these 3 things go together in this measure. Okay, the third one, our hospital governing board, in collaboration with leadership, ensures adequate resources to support patient safety, such as equipment, training, systems, personnel, and technology. Couple of perspectives here. Talk to any patient safety team in most organizations, and they'll say, we don't have enough resources to do the work that we're being asked to do, right? So of course, resources is important. But the other thing to realize is it's not just the people resources, but it's also resources such as technology and data. We can't access the electronic health record data systems because there won't be a data analyst, or the data analyst is only looking at business operations, doesn't have time to do any patient safety work, right? So imagine if you can get some data out of the electronic health record, do some cool analytics to figure out what's happening in patient safety. So that's another sort of really important item in this measure. Next slide. Okay, so let's go to the fourth item, which is reporting on patient and workforce safety events and initiatives such as safety outcomes, improvement work, risk assessment, event cause analysis, infection outbreaks, culture of safety, and other safety topics account for at least 20% of the regular board agenda and discussion time for senior governing board meetings. So I really like this one because it's ensuring that safety just doesn't become like a checkbox item. Yeah, we covered safety in our agenda. 20% might sound like a lot. People might say, wow, 20%. But imagine, it's the foundation. All high reliability organizations spend enough time on safety, and 20% is not too much to ask for. And remember, the other thing is, it's not just about 20% of safety related to sort of events and stuff that's bad that's happening. It's also the improvement work. You want to hear the good stories. You want to hear all the good news about how people are working in your organization on improvement work, putting into place tools and resources to improve safety. We often will be doing work in certain health systems, and the CEOs have no idea that they had this big improvement project in their organization because they never heard about it. And then lastly, is number 5, which is the C-suite executives and individuals on the governing board are notified within 3 business days of any confirmed serious safety events resulting in significant morbidity, mortality, or other harm. So why is this important? Well, oftentimes, the first time the hospital leaders hear about something is either they are sent a letter from a lawyer, or they read about it in the newspaper, right? Well, that's bad. We really want to try to get the leaders to hear about things that are happening right away. It also will not only sort of raise their situational awareness and of their motivations to do something, but it sort of raises what we call sort of the collective mindfulness of a healthcare organization. And that's what gets you towards higher reliability. So that's my take, and happy to have questions later. Over to you, Marty.
Okay, thanks, Pradeep. And now we're going to welcome Tejal. I'm so glad you're here, Tejal. The floor is yours.
I made it, Marty.
Marty, I'm tracking the questions, and there's a bunch of them that are coming up, and we can tackle at the end after we go through each of the domains.
Fantastic. Thank you.
Great. Well, I'm going to follow the same format. Thank you for having me. And so let's walk through the strategic planning and organizational policy domain. The first one, our hospital has a strategic plan that publicly shares its commitment to patient safety as a core value and outlines specific safety goals and associated metrics, including the goal of zero preventable harm. So there's some really important language in this one that I like and think is important to highlight. One is safety as a core value. We've heard a lot about safety has gotten deprioritized over the last several years, and we really wanted this language of core value because values don't change. Your priorities may, but safety has to stay firmly at the top as a critical, as the most critical element. And so we wanted to use that language of core value here and also include that goal of zero harm. There's been some debate about whether we should say zero harm that I won't get into, but the committee felt it was very important to actually talk about zero harm really as an important aspiration that makes organizations think differently and hopefully align their strategy around that different way of thinking. So the second one, our hospital safety goals include the use of metrics to identify and address disparities in safety outcomes based on the patient characteristics determined by the hospital to be most important to healthcare outcomes for the specific population served. This is also a really important one because we've been talking a lot the last several years about the connection of safety and equity and how we cannot have safe care if it's inequitable. And we have to really embed the equity lens into everything that we're doing around safety because we know harm does not happen equitably. There are certain populations at higher risk of harm. So really making sure organizations are starting to embed that equity lens is important. And I think this goal will, this particular piece of the measure will start pushing organizations in that direction. The third one, our hospital has implemented written policies and protocols to cultivate a just culture that balances no blame and appropriate accountability and reflects the distinction between human error, at-risk behavior, and reckless behavior. This one is also really important. We talk about safety culture as a foundational component of safety, and this just culture piece is a key component to that. If we're trying to build a culture where our workforce is feeling psychologically safe to report when they make errors, we have to have just culture in place to make sure that they are not inappropriately punished. And so, these just culture algorithms are very helpful for organizations to have a much more rigorous approach to addressing accountability while also balancing that non-punitive piece that's really critical. Let's move on to the next one. Number 4, our hospital requires implementation of a patient safety curriculum and competencies for all clinical and non-clinical hospital staff, including C-suite executives and individuals on the governing board, regular assessments of these competencies for all roles, and action plans for advancing safety skills and behaviors. This one I also really like, especially because it highlights C-suite and board members. There are known safety behaviors and skills that really have to become embedded throughout an organization and have to be not just for frontline folks, but for those leaders, as leaders can then drive behaviors and culture throughout the organization. And we talk about how important it is for boards to really lead on quality and safety. Well, boards have to understand equality and safety and have these competencies as well. So I think, ensuring that everyone is receiving this kind of training and then assessing how competent they are in these skills is going to be an important addition, I think. And then lastly, our hospital has an action plan for workforce safety with improvement activities, metrics and trends that address issues such as slips, trips, falls prevention, safe patient handling, exposures, sharps, injuries, violence prevention, fire, electrical safety, and psychological safety. And I saw in the chat earlier that there was some positive feedback about the connection of workforce safety and patient safety. This is really important. We've been talking for a number of years about workforce safety as really a precondition or a requirement for our caregivers and workforce to be able to deliver on patient safety. And so, we need a safe, engaged, psychological safe workforce to be able to deliver the safest care to our patients. And I think this particular component of the measure really highlights that workforce safety is this important aspect of patient safety. So with that, Marty, I'll pass it over back to you.
Okay, good. Thanks, Tejal. I'm going to pass it off to Rosie now. Rosie, before I start, let me just say, as I was listening to Tejal, I was thinking about how this domain in particular reinforces a number of things that CMS has put out there recently, like the emphasis on health equity, the zero harm goal, which is in the CMS quality strategy for the first time last year. So it kind of places this measure right in line with things that we're already seeing CMS try to encourage. Okay, Rosie, you have the longest set of slides. So without further ado, welcome. Rosie, are you muted? Rosie?
Marty, maybe you can unmute Rosie.
I'm sorry, I didn't unmute myself. First of all, I have probably the longest, and part of it is a little crazy. When you get the slides, you will be able to read the things that you can't read on this screen. But first of all, number 1 is hospitals conduct a hospital-wide culture of safety survey using a valid instrument annually or every 2 years with pulse surveys on target units during non-survey years. Results are shared with the governing board, hospital staff, and used to inform unit-based interventions to harm reduction. Now, the only thing I want to say to this one is, I think it also needs to be shared with patients and caregivers, because I think that many times the surveys, it's like closing the loop. We need to close the loop, and we need to make sure that we hear from, if we complete surveys, we need to hear what that survey says. And that might be like sometimes airing the dirty laundry, but patients have a right to have that transparency. Our hospital has a dedicated team that conducts event analysis of serious safety events using an evidence-based approach, such as the National Patient Safety Foundation's root analysis and actions. This is every hospital should have a committee that does this. And on that committee, there should be a patient. Now that patient probably needs to go through extra training or several patients, but I believe that this is very, very important because patients bring a different perspective to this. And many times, you know, I'm really believe in the whole root analysis, but I think that when we talk about when serious harm happens, and we don't, and it's heard about in the neighborhoods, and we always hear about them, but yet we don't have all the facts. It'd be a whole lot better if somebody was available and bringing that to the table. What are the things that needs to be addressed from the point of view of patients? Our hospital has a patient safety metric dashboards and use external benchmarks such as the CMS star ratings or other national databases to monitor performance and inform improvement activities such as safety events. Some of these events might be medical error, surgical procedure, or procedural harm, falls, pressure ulcers, diagnostic errors, and healthcare associated infections. Now, for me, the last two hold a lot of personal connections, and I live with, you know, a healthcare acquired infection, and I lost my husband to diagnostic error, and so it's very, very important that we have those star ratings and we have those databases that we can know things and understand things. The next page has things that are pretty small, and I'm going to try. And first of all, it says you should do a minimum of 4 of the following highly reliable practices. I believe all 6 of them should be practiced by every hospital, or 7 of them should be practiced by every hospital. But right now they're talking about 4 of them. Our goal would be 6 or 7. A tiered and escalated unit, department, facility, system, safety huddles at least 5 days a week, with one of those days being on the weekend. That includes key clinical and non-clinical personnel, such as housekeeping and security, units and leaders, with a method in place to follow up on issues identified. I believe that not only should these huddles happen on first shift, but they should happen on second and third shift. And all of these people should be included. I have to tell you that I sit on a facility advisory group, and I sit on an environmental service advisory group. And I have sat on these huddles, and often have been asked to come to these huddles. So this is a valuable place to be. Hospital leaders participate in monthly rounding for safety on all units, with C-suite executives rounding at least quarterly, with a method in place for follow-up on issues identified. I believe C-suite people I believe this should be weekly for hospital leaders and monthly for C-suite. Think about how fast patients move through your systems, and then think about how many people you might miss. So, at least if you do this weekly, you have a better chance. At least rotate leaders through weekly. The data infrastructure to measure safety based on patient safety evidence, like systematic reviews or national guidelines, and data from the electronic medical records that enables identification and tracking of serious safety events or precursor events. This data are shared with C-suite executives at least monthly, and the governing board at every regular scheduled meeting. I believe every governing board meeting should start with safety events and the precursor events. Again, this information should be shared with the public in some shape or form, at least with your patient advisory councils, because they are your voice in the community. Technology, including a computerized physician order entry system and a barcode medication administration system that promotes safety and standardization of care using evidence-based practices. This is just the minimal as far as I'm concerned, but especially the barcode for medication. I did a lot of research into this after some things that have happened in the last year, and I realized that there's two levels of this barcode medication administration, and there's the cheaper way to go or the better way to go. And the cheaper way looks like it might be easier and cheaper in the long run, but I'm going to tell you, if you make a medication error or have a safety event, that cost that you spend for the second level is just a drop in the bucket. And you need to be thinking proactively and not reactively. Too many times in medicine, we think reactively and not proactively. Use of a defined improvement method or a hybrid of proven methods, such as Lean, Six Sigma, Plan, Do, Study, Act, and other highly reliable frameworks. Use these methods to develop your safety plans, to approve things, and again, make sure there's patients involved from day one. The next one is kind of my belief in life. Team communication and collaboration training for all staff. I believe that we could solve all of healthcare problems if we could figure out how to communicate and collaborate better. Get out of our silos, get rid of our egos, and let's communicate. And we would have a better chance. And then the last one is, and I've been doing some work and research in this area, the use of human factor engineering principles in selection and design of devices, equipment, and procedures. And this is like an area that industry has been using a long time, and yet we don't always know about it, and we don't know how it relates to medicine. I encourage all of you to look at, are you using these kind of factors, engineering factors, as you choose devices or equipment or set up procedures and processes, and think about how industry might use it. You might even invite somebody from industry to speak to you about this area. I did a presentation in Boston a while ago about some research, and we were using this human factor engineering, and there was a lot of interest in it because it definitely connects our worlds. Then the final one is about learning health systems, and our hospital participates in large-scale learning networks for patient safety improvement, such as national and state safety improvement collaboratives, shares data on safety events and outcomes with these networks, and has implemented at least one best practice from the network or collaboration. It used to be that hospital associations was like the network that most people were involved in. Now, in my area, 3 states have formed a collaborative or a learning health system called Superior Health. And it's Minnesota, Wisconsin, and Michigan, and all 3 of their healthcare hospital associations work together on initiatives, and it's been phenomenal. And I have done some work with them on sepsis and other pain management and other projects, and you get different perspectives, and they they decide to work on a project and then they share their data, and they figure out real quickly who's really working on the project, who's just checking the box, and who's just saying, oh yeah, we're doing it, but they really haven't committed to it. And they call each other to task, and they make sure that others are aware of it. And so I'm passing it on.
Okay, thanks, Rosie. Tom Gallagher, welcome.
Thank you, Marty. And I was so pleased to see an entire domain devoted to the topic of accountability and transparency, because both are really preconditions to patient safety. And as Beth mentioned, they drive the learning that really runs throughout this structural patient safety measure. It's important that accountability and transparency are linked here conceptually. Transparency involves a number of practices around openness. And not only is it an important way of demonstrating respect for patients and families, it drives accountability. It leads us to acknowledge problems. It leads us to support those affected. It drives learning. So the five elements in this domain really focus on two primary areas. One is on reporting problems, and the other is on responding with accountability and learning. So item number one, our hospital has a confidential safety reporting system that allows staff to report patient safety events, near misses, precursor events, unsafe conditions, and other concerns, and prompts a feedback loop to those who report. Harm identification is vital, and without a good reporting system, you can't make much headway. I was glad they called out the issue of feedback loops. Our research and others has demonstrated that the absence of feedback loops really dampens clinicians' enthusiasm for reporting. I would note, though, as Rosie pointed out in the prior domain, there is an emphasis on the high reliability practice of using more advanced adverse event detection systems that hover over the electronic health record, which I think is an important area that the field is headed in. Number two, our hospital reports serious safety events, near misses, and precursor events to a PSO listed by the Agency for Healthcare Research and Quality that participates in voluntary reporting to AHRQ's network of patient safety databases. I think PSOs are a substantially underutilized resource in the patient safety world. And so I was very pleased to see them called out, but also to emphasize the participation in voluntary reporting to AHRQ's network of patient safety databases. The strength of PSOs lies not only in the protected space they allow for analysis, but the ability to aggregate and share to drive learning. Area three, patient safety metrics are tracked and reported to all clinical and non-clinical staff and made public in hospital units, e.g. displayed on the unit so that staff, patients, families, and visitors can see. Another transparency and accountability practice where we're reporting out our safety metrics in ways that others can notice. The last two elements relate to responding to problems with accountability and learning. Number four, our hospital has a defined evidence-based communication and resolution program reliably implemented after harm events, such as AHRQ's Communication and Optimal Resolution Toolkit that contains the following elements. First, harm event identification, open and ongoing communication with patients and families about the harm event investigation, prevention and learning, care for the caregiver, financial and non-financial reconciliation, and patient and family engagement and ongoing support. As many of you know, communication and resolution programs are principled, comprehensive, systematic programs for both finding, detecting harm events, and responding to them with transparency, accountability, and learning. And so I think it's wonderful to have them called out so explicitly here and to have the elements spelled out. It is important that this this number has both the words evidence-based and reliably implemented, because the number one challenge we see in the field is that of inconsistent implementation. And the primary mechanism for addressing that inconsistent implementation is in number 5. Our hospital uses standard measures to track the performance of our communication and resolution program and reports these measures to the governing board at least quarterly. The vast majority of organizations doing work on communication and resolution programs have no really way of knowing how well they're functioning. These measures are available from our group and others, and really are evidence-based ways of tracking how well is your CRP working for events that should go through this process, how regularly do they, and how many of these elements are used, and what are the outcomes like. So accountability and transparency really undergirds all things patient safety, and I think this is an outstanding addition to this measure. Marty?
Thank you, Tom. Okay, so thank you for the great information and for everybody keeping on time. It's you're making this easy. So we're going to get to Q&A in just a minute, but I want to just emphasize the urgency around the time frame that Beth mentioned earlier. We know that this is such a rich list of best practices that there's going to be some controversy about it. So our comments are going to be really important. As Beth mentioned, CMS basically requested that this measure be developed. They built a very, very strong TEP. I think the content you can see is very strong, and it's now our job to just really give them the kind of feedback, the kind of comments that are going to really reinforce this. I think many of you on this phone call know, maybe everyone knows, that CMS is obligated to read every comment made. They count them. The counting matters. So Patients for Patient Safety will certainly be submitting comments as an organization, but it's really important that, again, we get the number of comments out. And you can comment in a couple of different ways. There's a written comment period this year, and it started with the publication of this measure last Friday, and it goes through the 22nd. It's at the website of the contractor, Battelle, that is managing this whole process. This is what NQF used to do. Now it's Battelle. So please take advantage of the opportunity to file a written comment there. And I'm going to ask you, each and every person here, if you support this measure or even a part of the measure, just file a comment about why you support it and why it's important to you. And I'm also going to really encourage you to distribute this slide set and through your own networks and replicate the requests that they comment. And then there's a listening session that Battelle, again, the contractor, is going to do on December 15th. It's a long period. It's 6 hours. You have to register for it. In the registration process, you can ask to speak verbally on the phone call or on the webinar in support of a measure. They've asked us to identify this measure by number, which is 2023-188 in the MUC list. There's more information at the website. I have a question into them about whether there's an agenda so that we don't have to be there for all 6 hours if we're interested in just a few of the measures or only just this measure. So those are the opportunities we've got this year to get into the process before the Battelle committees meet, which are multi-stakeholder committees that will issue a recommendation to CMS, and they will consider all the comments that they receive beforehand. I'm on that committee, so is Rosie. We get a summary of the written comments and the verbal comments to consider as we generate our recommendations to CMS. And then next year, so that committee meets in the end of January, and after that, Battelle has told us there's going to be another public comment period after that. So the recommendations go to CMS, and there will be another opportunity for us to weigh in and talk about why this is important to us, why we think this is really going to move the needle. And then CMS will have the decision to make about whether to put this in their proposed rule for the hospital-based payment systems in the next fiscal year 2025, which starts on October 1. And that proposed rule is published in the Federal Register, usually in April. There's a 60-day period required by law to generate public comments, and we'll have yet another opportunity to weigh in with why we think this is so important. So Patients for Patient Safety files a public comment on this every year. We go through the entire muck list, and this year we will be certain to focus on this as something very important to us. But again, the more comments, the better, because the count matters. And then the final rule gets published pretty much after that, and we're off and running. CMS will sometimes implement, depending on the feedback, something right away. Sometimes they'll give hospitals a year to get ready for it. So that's just something to keep in mind. Creating a sense of urgency in our comments, I think, could be really, really helpful. Okay, Beth, that is kind of, I think, through our content. We now have some time for questions. I know you've been really monitoring a lot of activity in the chat room, but we can open this up for questions. Or maybe you've seen something in the chat room that you'd like to address to get us started.
Sure, Marty. First of all, I always love our chats because we have so many smart people that are like octopi with tentacles and so many different parts of how healthcare works, or in many cases doesn't work. And all of you are out there, each of us doing our little part to make things work better and be safer for patients. And so I just always love the chat because it's generating, oh yeah, this and that. So that gives me a lot of energy and joy. So thank you. And we're recording the chat, and we'll add those comments into the process and into our public comment. So one of the comments that came forward was funding for organizations to do this. I think this, I particularly work with hospital boards of directors, and I think the funding element and the resourcing element being put in the safety metric as something that boards need to discuss and evaluate how the safety is operationally funded is a real step forward. That's never been done before. So that's a very specific call out. I think also the alignment of this work with the National Action Plan at ARC that really offers some great resources to support these organizations in doing this, and connections to those resources would be another source of support. In terms of direct funding, if you're thinking of like the HEN work, that would be something that we would, that probably ARC and or CMS would have to work to get funded. So I think that would come after the measure is approved. So specific additional funding through like the HEN network would come after the measure is approved. But just by the effect that you're calling out that this is a leadership responsibility to ensure that safety is systemically trained and funded is a huge leap forward. That was one question. Another question that came up in the chat was who represents the community for PFACs. And that is not delineated in this network, or in this structural metric work, but certainly is an important element. I think, the metric is a pretty broad set of concepts. To get to that level where we're prescribing who's on the PFAC and who's not on the PFAC is probably maybe a little too in the weeds for this. But certainly if this came forward, there could be some opportunity for CMS guidance or ARC guidance on how to build a PFAC that would be representative of the community. So I think that would be work that would be good follow-on work to add the detail in the CMS guidance. And additional questions from the field that I might have missed in the chat. And I see some things coming, they put the link to, Lori put the link to the National Action Plan, which was really, just to emphasize that's not small work. That was a 2-year, really intensive work that many of you, I think, were on with IHI and AHRQ that really is comprehensive guidance with a to what organizations should do to oversee and create a safe health system. So it's really good work. It has a great assessment tool And I think this structural safety metric is really in alignment and building on that work. Additional questions, if anyone wants to go off mute and bring something up?
Yep. I suggested you raise your hand, but you don't need to. You can just come off mute and ask more comment.
We're not that fancy.
Yeah. And we have time.
Yeah.
Any other thoughts?
There was a question here, which I think is a good one. Will there be oversight of implementation of the proposed metric?
Oh, I saw that. You know, I think that's honestly the reason that a metric like this is an incomplete solution. I mean, this sends a signal to leadership that this is what we expect, but this metric can be gamed. I mean, this is attestation, and there have been, certainly in the consumer community and in many places, just a real emphasis on shifting to metrics that measure outcomes that really give us better data. So this is, I would say, a part of a complement of saying, here's what we expect. I don't think there's going to be a process for auditing, but certainly there are going to be a number of audiences that if they know about this measure, they'll be able to speak up if a hospital isn't doing it. I mean, that could be everything from patients to people within the organization to lawyers with lawsuits. I mean, I don't want to, I'm speculating here, but just by putting it out there.
Marty, I would say that I think that maybe we can make comments about auditing. I mean, maybe, when we have a similar measure for use of safer guides, ONC safer guides, for getting hospitals to use them, and it's an attestation-based measure, and we spoke to CMS, and they can ask, can you tell us, when you said yes, what did you look at? And the other ripple effect will be with Joint Commission and others who will ask, oh, looks like you've been sort of attesting to this. Can you show us your plans to implement this item? So somebody can ask questions.
Hardeep, I kind of think that this is like CMS has these structural measures because they found them really effective in motivating organizational behavior. That it's a little bit of a carrot that it allows organizations to really pause and think about, are we doing this? But certainly there's an accountability element that eventually you can have that Joint Commission review, you can have the public reporting element to, you can have the element of fraud. If you're attesting to something and you're getting recognition for it, but you're not actually doing, there's certainly holding leadership accountable for that inaccurate attestation. So, but I think this is more of a carrot towards good behavior than a stick towards, catching organizations or gotcha. I mean, it's really a strategy to use these attestation measures to advance safety in a space where, it's giving better guidance and tools towards that. The other thing I wanted to add, there was a question of like, how do you get the points? You have to check all the boxes in a domain to get that domain point. There's only the section that Rosie talked about where you have a choice of choosing 4 out of the 7, I think it is.
Right.
So, the CMS will do audit measures, but it will be minimal. But I would just emphasize, like, it's pretty frowned upon to lie to CMS because in theory, it will affect the ability to participate in their programs. So, I think this is the carrot towards good behavior, towards, safer systems, and it aligns so well with the National Action Plan guidance and support tools that it's kind of piecing these fragmented parts of healthcare together a little bit, which I kind of like.
Great. We have 2 hands raised, and Yanling, I saw you raise and then lower your hand. So Carl, why don't we go first to you and then Rosie and then Yanling?
Sure. First of all, I want to thank everyone, especially Nicole, for the invitation. This is the first introduction I've had with, I guess, the patient safety environment. So I feel humbled by some of the comments that I've heard. And I would sufficiently say be inadequate to make comments regarding the intricacies of it. But I did see something that I had to, I thought that was a very interesting parallel. I represent, I guess, patient blood management. And many of you may be familiar with patient bud management. The protocol has been for many years, 10 years. But in some of the comments regarding equity, safety, and patients being now collaborative, multidisciplinary approaches, I thought that this patient safety is an incredible umbrella. And some of the, I guess, evidence-based practices have already been proven with patient bud management. So if anything, patient bud management may be a wonderful tow truck that you don't have to now ask for credibility because that platform already exists. The problem with patient bud management is interesting because it's just the opposite of what you're doing. The patients have no idea that it exists, nor does the public. And when you enter into a hospital structure, there should be some type of signage that allows a patient to know that safety does exist. You know, here we're trying to prove that safety issues do exist to the hospital level, but a patient should know. There should be signage, there should be directions. If I need to have a chat with someone that's personnel, I need to know where to go. I saw one hospital facility, I think it's Mayo Clinic, they're doing billions of dollars of infrastructure. But the question is, what's the use of having infrastructure if the patient still doesn't know where to physically go? It's nice to have a beautiful hospital, but if you don't know where to get the feedback or the collaboration or the information that you need, is a problem. As far as World Health Organization, patient bud management has been already, they're actually issuing that globally. Joint Commission is just at least an accreditation and a certification just over the last month for patient bud management. And some of the key points that you raised, I think, are embedded within that. So, you know, I would love to chat. You know, I would love to chat with someone regarding this, because this is maybe this is a new marriage that should exist that maybe had never even been entertained.
Carl, I'm going to invite you to join Patients for Patient Safety. Go to our website. You can join as an individual or an organization. We orient champions every month 3 times. We've started with 10, we've gone to 80. So we welcome you there. We are at time, so I think we can take some more questions. But before people start leaving, please know that the slides and a recording of this webinar are going to be posted to our website. Armando gets these stuff really fast, and we will encourage you to distribute it. Take the slides, use them, take the recording, share it with other people in your network, and ask them to file public comments.
Yeah, the most important thing is please file public comments. That's really, really important. I know not everybody likes to do that. We need this group. All of you are leaders in your different patient and safety communities. We really need you to step up and take the literally under 5 minutes to file a public comment. In the slides, you have all the information you need to do the public comments.
And Carl, I didn't want to cut you off, but I have to kind of manage time here. Rosie, you're next quickly, and then Yenling.
Yeah, I'm going to go quickly. First of all, globally, you know, I believe many of us work globally already, so we bring the global voice with us. But also, you know, the woman from Canada, if you want to reach out to one of us and share your thoughts with us, we will take them public. I have no problem, you know, using your voice or bringing your voice with us, because I believe we all learn from each other. And if we really, really believe in learning health systems, they have to be more than just the US's learning health systems, but they have to be the world's learning health systems. And so I believe we have a whole lot of work to do in that yet. But, you know, I believe also that we all teach, we all learn. So I think we can learn from each other and work together.
Okay, thanks, Rosie. Yenling, I have lost track of you on my screen. Maybe you had to leave, but thank you everybody for coming, and please help us get the word out about how important it is to file public comments.
And Marty, if anyone has additional questions, why don't we hang on for like 2 more minutes here if people need any last questions?
Okay, that's good.
Do I have a time to comment on, Marty?
Yes, Yenling, I just didn't see you. Yeah.
I can't raise my hands, maintain there for a few seconds. Thank you. I just think this is a great, the webinar, and I'm so glad that CMS now put the zero harm on the top of agenda. We have a goal, and concerning the structure measure, I think it's important definitely that the public also know how the hospital doing in those measures. One thing I sort of suggest, not just on CMS hospital comparison website, but also on hospitals' own website. They can put this up, just say that, tell the public how we are doing. This way is really to gain the public trust that they keep working together. We need all working together. So that's just my suggestion. Thank you.
Well, yeah, Ling, that's a good suggestion, because I think Hardeep was getting to this too, but these attestation measures are evolving. I mean, so I think that this is like the first shot we're going to have to get this one done, but CMS will watch it, they will see what works, and they'll take suggestions, I think, going forward. Any other comments before we break?
I want to thank you, Marty, for taking the lead on putting all these slides together and making sure that making it so easy to understand, and for our presenters for each kind of diving into one of the parts of this really impressive metric. So thank you all for putting it together.
My pleasure. Thanks, Beth, for partnering with me on this.
Yes.
And Rosie and Hardeep and Tejal's gone, I know already, but and Tom, thanks very much for doing this. We didn't have a chance to rehearse. We were so driven by time, so everyone just kind of jumped in and swam in their lane to the end of the pool.
I think we.
All right. I think we're all set, Marty. We'd probably wrap up.
Bye, everybody. Thank you.
Bye, everybody. Take care. Yep.
Thanks so much.